Bismillah ar-Rahman ar-Rahim. Good evening, everyone. Welcome to I believe, the second neuromuscular series for this year. Today will be rich in ALS, diagnosis and management. Our first talk would be done by Dr. Weber, who's a professor of neurologist in Switzerland. He's the founder of Neuromuscular and ALS Clinic in Kantonsspital Hospital in St.Gallen in Switzerland. I was glad to hear that he was having fellowship in British Columbia, where the country where I studied and did my fellowship. And he has many publications, at least 100 peer-reviewed publications, and had made some chapters in books. He's also head of neuromuscular unit in St.Gallen Hospital. He has vast experience in ALS management and treatment. And here I'm very honored and privileged to have him here and doing the first lecture for the new perspective in management of amyotrophic lateral sclerosis. Dr. Weber, welcome.
Well, thank you so much, Dr. Al Madani. It's a great pleasure to be again here and to talk to all of you. And I would like to express my gratitude also to the Biologix for sponsoring this symposium, ALS, and about the challenges. And I think this makes a lot of sense to think about ALS in terms of challenges. First, here is my conflict of interest statement. I have no commercial interest in any of the drugs I'm going to mention, but this is the list of pharmaceutical companies. I am on the advisory board. So coming back to the challenges, I think I'm going to talk about two different issues of ALS. First, I'm going to talk about making an early diagnosis. What's the challenge in making an early diagnosis? And the second part will be about the challenges in the treatment of ALS and the application of Edaravon, because there we have a new medication. So let's start and look at the diagnostic process first. A few bright people, amongst them Michael Swash, one of the giants in ALS, has subdivided the diagnostic process in 3 different periods. And the first period is from onset of symptoms to first medical contact. The second period, until the patient sees the neurologist, and then the final period until the diagnosis is established. And I think it's not very surprising that it takes about 5 months before the patient goes and sees the doctor. Why is that? Of course, symptoms are very, very subtle. And if a 70-year-old starts to fall or to stumble, he is not going to see a doctor right away. But then it takes another 7 months until the GP realizes we are dealing with a neurological problem. And then the patient will be sent to a neurologist, and sadly enough, the neurologist will take another 4 months to establish the diagnosis. Well, you could argue this study was from 2000, and it's Great Britain, public health. In Middle East, it's different. There is a lot of money and diagnosis is made much faster. Well, Adriano Chio from Italy made a survey asking different specialists from various countries. You see here Germany, Italy, Spain, Argentina, Brazil, United States, and asking how long is it going to take for your patient to go to the GP, to see the neurologist, and to establish the diagnosis. And what you see here in this graph, regardless where you live in the world, in average, it takes about 12 to 14 months until the diagnosis is established. So it doesn't seem to matter where you live. Making a diagnosis seems to be a challenge. Looking 14 years later, this was 2000. The title tells you everything. Delayed diagnosis, the problem continues. Meaning over 14 years, nothing has changed. And another study from the United States, again from 2014, the median time to make the diagnosis is close to 12 months. And in average, the patients see 3 different physicians before they get the right diagnosis. And half of the patients will receive an alternative diagnosis, first of all, neuropathy, and then also spine disease. Going again back to the year 2000, Adriano also asked the specialists, so what are your misdiagnoses? And what we see on top of the list, neuropathy, medullary compression, and then some other diagnoses. Meaning, over a period of almost 15 years, nothing has changed. The delay is the same, the misdiagnoses are also the same. And interestingly, neurologists contributed with 28% to the wrong diagnosis, GPs 29%, orthopedic surgeons 26%, and other specialists 18%. So we see it's not only the GPs which make the wrong diagnosis, but also neurologists. We can look at this also from 2 different perspectives. First, we can look how many patients get a false positive diagnosis in terms of misdiagnosis, meaning these patients did not have ALS. And there we have the Scottish Motor Neuron Disease Register, and 10 out of 552 incident cases got the wrong diagnosis. As a matter of fact, they did have cervical spondylotic myelopathy, MND plus syndromes, and multiple sclerosis. Very similar in Ireland, 7% are misdiagnosed. As a matter of fact, they had multifocal motor neuropathy, Kennedy's disease, and motor neuropathy. The other perspective is how often is the diagnosis missed? So this would be false negative. And Martin Turner has looked at bulbar onset patients and found that 50% of patients with bulbar onset are first referred to another specialist, otolaryngology and stroke clinics. And if we look at patients who underwent surgery, there is a retrospective cohort. 12% of these patients will have surgery prior to diagnosis. And if we look at the neurosurgical cohort, 4.2% of all spinal decompressive surgeries are in fact ALS patients. So it seems that making an early diagnosis is a real challenge. And probably most of you would agree if I tell you that the most important tool in making the right diagnosis is our reflex hammer. And why is that? As you know, the El-Escorial criteria have been around for some time, for more than 20 years now. And they are still in use for clinical trials, which underscores their importance. We have the 4 regions: brainstem, cervical, thoracic, lumbosacral. And I believe it's not so difficult to detect lower motor neuron sites because weakness, atrophy, and fasciculations are pretty obvious. We see this immediately. And again, we go for the different regions. In my view, the major challenge are the upper motor neuron signs. Of course, we all look for spasticity and for a positive Babinski sign, but a positive Babinski sign actually is very rare in the beginning of ALS. Only 30% will have a positive Babinski sign. And whenever I teach my residents, I tell them, please read the fine print of the ALS criteria, because there it is nicely defined what are upper motor neuron signs. For instance, a preserved reflex in a weak wasted limb is an upper motor neuron sign. So we do not necessarily need exaggerated reflexes. If we have a preserved reflex in a weak wasted limb, we know this is upper motor neuron. Other features, a clonic jaw jerk, gag reflex, a snout reflex, or look at that, forced yawning. The people who wrote the original ALS criteria were very bright people. Who of us asks the patient whether they have forced yawning? According to these criteria, it's an upper motor neuron sign. And I think this is really helpful. And just to summarize this and to repeat this, there are more upper motor neuron signs than the Babinski sign and spasticity according to the ALS criteria. In the bulbar region, we have a clonic jaw jerk, we have exaggerated snout reflex, emotional lability. Ask the patient if his emotions have changed. Forced yawning. In the cervical and lumbar region, we have clonic deep tendon jerks, Hoffman reflex, as mentioned, and I'm going to repeat that, a preserved reflex in a weak wasted limb, and also hyperreflexia is clearly defined. Hyperreflexia is a spread of deep tendon reflexes outside the stimulated territory. And a spread is involvement of new anatomic segments or regions in the central nervous system. So for instance, if I show you my hand, if I tap the brachioradialis reflex, this is usually the brachioradialis reaction, and I get the response of my finger flexors. We have a spread of reflexes. This is an upper motor neuron sign. In the abdominal region, we have loss of superficial abdominal reflexes. And what I personally always do is I try to elicit deep tendon reflexes from proximal muscles, such as the trapezius and the pectoralis reflex. And I'm going to show you an example here. And this is for the residents. If you do not routinely do the pectoralis reflex, look at that. Now I have to move this forward. Do you see that? It even spreads here to the biceps reflex. I'll show this again. No, let's go back. Look here, it jumps to the biceps. So this is abnormal, and the jump to the biceps is also abnormal. If I move to the leg, here we have a crossed adductor reflex. But of course, we also have tools to assess low motor neurons. And we all love to do EMG, and I'm going to show you a few examples later on. I had a wonderful mentor in Vancouver and Ryzen, and he said, EMG is an electronic patellar hammer, and in the right hands equal to the clinical exam. And the people who wrote the ALS criteria, who revised the initial criteria, knew that EMG can indeed be very, very helpful. So in the original ALS criteria, we had 4 categories: suspected ALS, which were over low motor neuron signs. We had possible ALS, upper and lower motor neuron signs in one region, probable ALS, upper and low motor neuron signs in 2 regions, and definite ALS, upper and lower motor neuron signs in 3 regions. But then they said, well, yet let's utilize EMG. In the original criteria, there were only clinical findings, and they introduced a new category, which was probable ALS supported, allowing EMG findings to be taken into account. And the requirement was signs of active and chronic denervation. At the same time, the suspected category was abolished. But now we had the situation. There were 3 categories possible: probable, definite, based on pure clinical exam, and 1 category allowing EMG to be taken into account. By the way, EMG is a pretty old method. The first evidence that a muscle can be stimulated electrically was Galvani, 1792. Here you see the experimental setup. And the first EMG was recorded 1849 by Dubois-Raymond. So that's pretty amazing. These are fairly old methods. So when we do EMG in a suspected ALS patients, what are we looking for? Well, the first thing what we are looking for is, of course, we are looking for spontaneous activity. You see, here are positive waves. And once in a while, there was fasciculation. But there was another one. So the question is, and this is another question to the residents, if your patient comes with right-hand-sided weakness and the patient allows you to do only 1 single EMG, where do you go for your EMG? Do you go to the right side where the weakness is, or do you go to the opposite side? Well, you go to the opposite side, because on the right side, you already know that you have low motor neuron signs. But usually there is a spread of symptoms and denervation. So if you find signs of active denervation in the opposite side, in a strong muscle, you can be pretty sure that this is ALS. The other feature we are looking for are signs of chronic denervation. You see a complex motor unit potential, and what you also see is very unstable. The components are jumping around, and this is called a jiggle. And look at the amplitude. The amplitude of the major component here is about 0.4 millivolts, so it's not increased at all. But as you can see and hear, it's a very unstable motor unit potential. So having said that, with the different categories, there was a group who sat together, and you see the names here on this publication, Mamede de Carvalho, Andrew Rice, Michael Swash, all the big guys in ALS, and they said, it doesn't make sense to have 3 categories with clinical findings and 1 category with EMG findings. Let's revise the criteria and let's go back to the principle EMG and clinical findings are equivalent. And this was the birth of the Abaji criteria. So the category probable lab support was abolished, and you could take EMG into account for all categories. The $1,000 question is, do Abaji and El Escorial criteria work in everyday clinical practice? Well, and we were fortunate to participate in a study. This was a quite interesting approach. The charts, EMG findings and clinical findings of 399 ALS patients were sent out to ALS specialists in Europe. And these ALS specialists were asked to classify the findings according to Abaji, and which is gray, and revised ALS criteria. And then the kappa coefficient of correlation was calculated. A kappa coefficient of 1 here would mean perfect agreement among the specialists. A kappa coefficient of 0 means no agreement whatsoever. But now, look at the category probable lab supported. Agreement amongst the specialists was only 30%. And if we go to the category probable and definite, the agreement for revised ALS criteria is 50%. It's less for Awaji. The best agreement was for non-ALS. But I mean, this tells you something. In everyday practice, neither Awaji nor ALS seems to work. And probably because of that, there have always been attempts to simplify these criteria and to revise them. The first approach was made in 2015 by the WFN research group, but not much attention was paid to these criteria. Another attempt was made 2019, again by the WFN, which is called the so-called Gold Coast criteria. And the bottom line in both criteria was possible ALS is ALS. So if we see upper and low motor neuron signs in one region, this is ALS. I'm completely happy with that. And as a matter of fact, studies from clinical trials have shown once you diagnose possible ALS, it will progress to full ALS. But I disagree with the EMG findings. In this Gold Coast criteria, they say there needs to be evidence of chronic neurogenic change defined by large motor unit potentials of increased duration and or increased amplitude, with polyphasia and motor unit instability regarded as supportive but not obligatory evidence. And I think this is wrong, and perhaps we can discuss this. And in my experience, the opposite is true. And I'm going to show you again the EMG finding here. This is ALS. This is a complex, unstable motor unit potential. The amplitude here is normal. The amplitude is just 0.4 millivolts, which is perfectly normal for the tibialis anterior muscle. The interesting thing here is the instability. And this is one thing you find always if you have loss of motor units and remodeling. And now I'm going to show you another motor unit potential. You see two things. It's rapid firing. It fires very rapidly because motor units have dropped out. And if you look at the size of the motor unit, one unit here on the screen has 0.3 millivolts. So this is about a 5 millivolt large motor unit potential, which of course is unstable. Is this ALS? No. This is Charcot-Marie-Tooth disease type 2, a very, very, very chronic disease. In ALS, there is usually no time to re-innovate and to build up these large motor unit potentials. And this is just the summary how the various criteria developed. Initially, we had ALS choreal, we had the presence of ALS definite, probable, lab supported, possible. Lab supported was abolished in Abaji, and now in the Gold Coast criteria, we have only the presence of upper and lower motor neuron signs in one region, or low motor neuron signs in 2 regions. But there are also clinical clues. ALS is never based on neurophysiology or clinical grounds alone. In the end, it's a combination. As you know, it's always focal. We have a split hand, we have a foot drop. Almost always unilateral. The finger flexors are usually strong in ALS until the far end. And this is opposed to inclusion body myositis, where finger flexors are affected first. The grade of weakness and wasting are proportional. For instance, in multifocal motor neuropathy, we have weak limbs, but almost no atrophy in the beginning. And this is not the case in ALS, it's proportional. If we see tongue wasting and fasciculations, only this symptom has an 80% predictive value for ALS. And personally, if I do not see fasciculations, I get very, very nervous and I think of other diagnoses. Neurophysiology, as shown, we have chronic EMG changes. This is mentioned in LSQL. We have unstable MUPS, we have the jiggle. It is mentioned in Avaji and LSQL. And we have signs of active denervation in strong muscles, which is mentioned in the Avaji criteria. And I really like to re-emphasize this. If you find signs of active denervations and fasciculation in a strong muscle, I don't know any other diagnosis than ALS where this would occur. And again, according to the Gold Coast criteria, one region is enough to diagnose ALS. So I'm at the end of the first part with respect to diagnosis, and I would like to hand over to Dr. Al Madani for a discussion and for questions and answers.
Thank you, Dr. Weber. Excellent talk. Just getting very good feedback from the team and the audience. We reached up to almost 900 participants.
Oh my gosh.
So
it's an honor.
900 was nothing, as it.
Thank you so much for your interest.
Okay, so the Gold Coast criteria has made a dramatic change. If I present my case now, or we can present it later on, it's up to you, Dr. Weber. What do you think?
Well, if your case is a diagnostic challenge, it might well fit right now. So yeah, perhaps
let's ignore that you say that present reflexes and weak muscles are upper motor neuron sign, and we put it as a normal sign. Okay. Let's go ahead and present my case.
Just to make clear, this is not my idea. This comes from Ben Brooks, Michael Swash, and all the big guys.
Yeah. That changes the whole paradigm in diagnosing ALS. So this is a case, Dr. Weber, whom I've seen 2 weeks ago. Okay. I've seen this patient as second opinion. It's a 51-year-old right-handed male who's known case of coronary artery disease, and he had CABG in 2017. He has hypertension as well and hyperlipidemia, for which he is on X4, aspirin, and omega-3. His weakness has started on the left leg. He's a bodybuilder. He looked like Shah Rukh Khan, is a very famous Indian actor. Very well muscle built. And that's what he noticed. When he was squatting, he was having difficulty, especially on the left leg, and he was very animate on this. The one which was very perplexing, because a cross sign, when you see cross sign, you don't think about ALS, right? So he had left leg weakness, then he started developing, as per his comment. Weakness on the right arm, along with neck flexor weakness. That happened in 2020. So in 2021, he noted problem with left arm weakness. He was unable to stand from sitting position. He experienced, or he noticed by himself and his wife, twitching of the whole body. And that year he lost approximately 5 kilograms, but overall he lost approximately 25 kilograms. He started experiencing swallowing problem. He started retaining his saliva when he was brushing his teeth, especially chewing problem with change of his voice. There was no pseudobulbar symptoms, no extraocular movement problem, or no bowel bladder symptoms. This was his exam. He had tongue fasciculation, though tongue movement was normal. Snout, pout was all normal. Gag was possibly present or absent, but not brisk. He had wasting of the whole muscles. Power was in this, and the right was 4 minus, and left was 3. So that was doubtful for me. So when I see power on the left arm is weakest among the all, I wonder whether he had problem on the left arm before all these symptoms started. So when I see the power exam, I think probably his weakness started on the left arm. Triceps was 4 minus 4 plus, biceps 4 minus, FDI was 4 minus 4, adductor digiti minimi was 4 minus, finger flexors were fine, hip flexors were 4 plus. Remember, he told us that he started having weakness in the left leg. When I see him in the exam, I do think that probably he started having weakness on the left arm before all other symptoms started. So all these weakness goes with the root rather than the nerve. Reflexes are 2 and plantars are downgoing. So if you implement your or the panel's criteria, the reflexes are brisk because considering it's 2 and the weak muscles. Yeah. Plantars, however, were downgoing. Sensory was fine. There were no clonus. Abdominal reflex were absent, so that you can wonder whether there's upper motor neuron sign in 3 areas. So blood work were done. So this case was sent to me as a second opinion because the neurologist thought he did not elicit any upper motor neuron sign. Mm-hmm. So where he started thoroughly investigating the patient with blood work, paraneoplastic screen, MRI of brain and spine. LP was not done though nerve conduction studies were done and it showed only perineal neuropathies. What I did, I repeated the nerve test. I agreed with him. I find though the perineal responses were, he got 1 in both as an amplitude, but I got 0.7, 0.1. Though you are comparing chicken with the egg, right? Because we are using different machines. Yeah. That was the only abnormal findings, perineal neuropathy. There was no conduction block, no temporal dispersion, whatever. So that was the EMG findings I found. Fibs and positive waves in most of the muscles. F6 and L3-4, reduced recruitment. L5 root was involved, so at least 2 roots were involved in the leg. Paraspine was involved, and L4-5, S1 as well. Thoracic paraspine was involved, so he had lower motor neuron findings in at least 3 segments. Also, the arms were involved, and I purposefully did the right side because it's less weak than the left side. And he had positive sharp waves, fasciculations, reduced recruitment, and increased polyphasia. And I fully agree with you. I don't always see a high, large amplitude in many muscles, and I do see most of those people are having ALS. So you discussed this, Awaji and ALS Corial. So the really revolutionary finding on the ALS Corial is the present or +2 reflex in a weak muscle you should consider as upper motor neuron sign. So let's say that's not an upper motor neuron. So that's what the neurologist who sent it to me thought. You did not find any upper motor neuron sign. He did not consider +2 reflex as an upper motor neuron finding. So let's consider this. Even if he was right, if you go to Gold Coast criteria, if you had progressive lower motor neuron findings in two segments without any upper motor neuron finding, this is ALS if you exclude other findings as well. So the challenging thing for me was whether he really had cross finding. I don't think that he had cross finding because his left arm, if you go back to my exam, here, his left arm was the weakest side. So I doubt whether he had, I wonder whether he had weakness in the left arm to begin with, then it moved to the possibly left leg or the right arm, because he started having, when he noticed the arm weakness, he started noticing bulbar symptoms. So I diagnosed him with ALS, but though I wanted to make sure, because he's young, I want to do CSF study. I asked for PET scan and GM1 antibody just to make sure that I'm not missing multifocal motor neuropathy. I started him on Radicava. I think the Biogen group are helping me with purchasing Radicava for him. When I saw him last time, yesterday, I was wondering whether he started having pseudobulbar symptoms because he started laughing when I gave him bad news. So that was not a good sign, but it's a good sign for me that I diagnosed him with ALS. So that was referred by a neurologist for me, thinking that he has only lower motor neuron findings. But though with the new ALS Corial, revised ALS Corial criteria, that would be considered an upper motor neuron finding with a present reflex and weak muscle. Even though if you say that +2 reflexes not considered upper motor neuron, having lower motor neuron findings in two body segments, that per se fulfills the Gold Coast criteria for ALS. So hereby I finish my part. Any questions, Dr. Weber?
No, I don't have any questions, but I have, if I may, I have 3 comments.
Yes.
The cross pattern, meaning
yes.
left leg, right arm, or vice versa.
Mm.
This pattern we see in about 10% of patients. Usually it's left arm, right arm, left arm, right, but sometimes it's really crossed. Mm-hmm. The other issue is, as I have mentioned, if you simply take tongue fasciculations and wasting, and obviously he had dysarthria, the chance of having ALS is 80% without any further clinical symptoms. And the third issue, you had fasciculations in the quadriceps. I think as long as you have fasciculations in the calf muscles, we don't care about this. I do have fasciculations in the calf muscles as well. But once it's above the knee, you start to get nervous, especially in the combination with signs of active innervation. So I think you are perfectly right. And what I learned from your case is that the old guys from ALS Corial, they knew a lot about clinical presentation of ALS, because all what you told me, or all what you told us, which came on later, confirms You know, you have the emotional ability, which came on later. And I saw there's a question about forced yawning in the chat. One comment about forced yawning. If it's really severe, the patient will be sitting in front of you and yawn all the time. And if you ask him, are you tired? He will say, no, I'm not tired. So I think the symptom of forced yawning is the same as hypersalivation. This is and emotional ability. It's disinhibition. And sometimes they have it only episodically at a certain time of the day. In the afternoon, they get frank yawning. It lasts for an hour, and then it's gone. But the clue is, the question is, you need to ask the patient, when you start to yawn, are you tired? Yes or no? Because at least from my side, I only yawn if I'm tired. I don't know about you, Dr. Al Madani, but usually we only yawn if we are tired. So
I fully agree with you. That's the new information for me myself. That yawning is considered as an upper motor fine. Well, I was seeing this in ALS Korea, but I wasn't paying attention to it. But that's a good thing to remember.
The yawning, the emotional ability, the gag reflex. This is all points to disinhibition. I mean, for instance, I ask the patients if they watch video, and if they watch the news and something serious has happened, like an accident, whether this affects them emotionally. And many of them will tell me, well, you know, I'm getting really sad. Usually you can, of course, you are in a distance to what happens on TV. But if you affects personally, this is also some sort of indication that there is emotional ability. It can be very subtle.
I'm actually getting questions, and you answered most of these questions about the forced yawning. I think we can go ahead with your next session, Dr. Weber.
I saw, if I may, I saw one interesting question. Do muscle twitches interfere with patient sleep? This is the last Raquel Amor. No, it's very rare that the fasciculations bother the patients. Very rarely they tell me that they are bothered by the fasciculations. And the next question is, how long do people with ALS live? Well, between 6 months and 50 years, like Stephen Hawking. This is the range of survival. And then Dr. Petty, could the challenge lie in the fact that early on patients do not fulfill the criteria of any schema? This is a very good question, Dr. Petty. You know, how long do we have to wait until the patient fulfills the criteria? And this is why I'm very happy about Gold Coast. I mean, many centers, you know, they found upper and lower motor neuron signs in one region and said, well, it's not ALS yet, come back in 3 months. I think this is the wrong approach. And in this regard, the Gold Coast criteria are helpful. If you see upper and lower motor neuron signs in one region and you have excluded all the other causes, you may diagnose ALS. And it doesn't help the patient. We never tell the patients you have probable ALS or you have definite ALS. It doesn't make sense. The patient only wants to know, is it ALS or is it not ALS? All right, and this now I can, how early do we need to make the diagnosis? As early as possible, because ALS has become, for some patients, a treatable disease. And I'm going to show you a very spectacular video at the end of my presentation. But regarding the diagnosis, and now I'm going back to my presentation.
Just giving you a comment about how long people can live. There was an ALS patient whom we diagnosed in 2001. I left to Canada for studying. We told her that you're going to die in 6 months to 1 year. I came back, saw her alive, but she was intubated though, but she was still alive. She kept telling me that you guys told me I'm going to die, but I'm still alive. So I always be judicious with telling them how long they live, because it differs from patient to patient.
Dr. Al Madani, thank you for this comment. We never tell the patient anything about survival, because when you see the patient in the beginning, we simply don't know. We do have we can estimate this. For instance, if the patient was a marathon runner 6 months before he comes to your office and then has frank weakness or is in a wheelchair, you know that this is aggressive disease, or vice versa. If the patient started to develop symptoms 3 years ago and it took 3 years to make the diagnosis, you know it's a more slowly progressive course. But in the end, you never know. I've seen patients in whom the disease stopped. I've seen patients who got better. And so it's really just simply say, you know, we have to cope with the disease, we have to treat the symptoms, maintain quality of life, and also slow down as fast as much as possible. And this brings me to a very bright lady. Her name is Baroness Finlay. She's a professor of palliative care. In 2009, at the ALS Congress, she said 3 important things, which I always bear in my heart. Diagnosis is a key. Why is that? Although it's a horrible diagnosis, as long as the patient does not know the reason for his progressive weakness, he will be desperate. The only chance to cope with the disease is if you know the diagnosis. And even though we can't cure it, most patients are thankful to know what they are dealing with. The second issue is, if you don't get communication right, you don't get anything right. And this is so true also for everyday life. We have to listen to our patients. What are their needs? What are the symptoms? What do they tell us? And everything they tell us a symptom, for instance, early morning headaches, we have to ask, is this something treatable? And the first symptom in ALS, if you have respiratory distress, is not dyspnea, it's early morning headaches because they have nocturnal hypoventilation. So we always have to ask ourselves, is this something treatable? And the way we try to do this in St.Gallen, I'm not saying we are perfect. When we see the patient first, the neurologist has 2 hours. He does a clinical examination, takes the history and neurophysiology, and then if we think it's ALS, we call in a specialized nurse, and then we break the bad news and tell the patient about the diagnosis. And then the patient goes with the nurse for another hour, and she will explain medications and any aids which might be helpful for everyday practice. She also will do a pulmonary function test and the ALS-FRS score, which we are going to talk about later. After 4 weeks, we have the patient come back. No examination, no clinical tests. We simply would like to know, how are you doing? Do you tolerate the medication? And so on and so forth. 1 hour with the neurologist, 1 hour with the nurse. And then we switch to a 3-monthly interval. We see the patient, the neurologist sees the patient for 1 hour, and his main task is to identify problems, to do a clinical exam, and then another hour, the ALS nurse will explain new medications, will do the ALS assessments, and then as needed, we will call the physiotherapist, speech therapist, nutritionist, and so on and so forth. So having said that, when talking about the treatment of ALS, we are looking at 2 pillars. The first pillar is, what medications do we have available to modify disease progression? And the second pillar is symptomatic treatment for maintaining quality of life. And we every time we tell this to the patient, listen, although we cannot cure the disease, we can give you medications that really relieve your symptoms, maintaining quality of life. And the vast progress has been made in this area, as you may know. Talking about disease modifications, riluzole has been around for a while. And this is the pivotal study showing that after 6 months, the placebo curve and the Verum curve deviate, showing that riluzole prolongs survival. The problem here is this study was published in 1996. So we are looking at 25 years. And after that, it wasn't that there were no clinical studies, but there was a 20-year history of failed clinical trials. Over 60 clinical trials with various medications failed to show any slowing of disease progression. But this scenario changed in 2014 when the Mitsubishi launched a phase 3 trial with Edaravon. And this study was positive. However, it took 14 years for drug development, implying that this approach was not straightforward at all. And I will tell you why this was the case. But before I do this, we briefly review Edaravon. Edaravon is a low molecular weight lipophilic compound which is important for ALS treatment because it crosses easily the blood-brain barrier. And this is the major challenge for all ALS drugs. The question is always, how fast does the medication go into the brain and spinal cord and reaches the target? We know in ALS there is oxidative stress, and Edaravon was initially approved for the treatment of acute ischemic stroke in Japan because it reduces oxidative stress. And this was the whole idea for drug development in ALS. And in the first trial, which was 2001, in 2001, this was a phase 2 study, the main clinical outcome measure was the ALS-FRS score, which is still used in any clinical trial. I'm sure you know the ALS-FRS score, which is an item of 12 different subdomains, and in like walking, handwriting, and so on and so forth. And in each domain, you can reach a maximum of 4 points. And this score, and they applied what is called a lead-in design. So for 3 months, they observed the patients, and then they were randomized to placebo and to Edaravon. And when they compared the slope before and after treatment, the slope changed from 4.7 points to 2.3 points. So this is the progression rate over 3 months before, and this is the progression rate after initiation of treatment. They also looked at the biomarker, which is the 3-nitrotyrosine levels. It's a marker of oxidative stress. And here you see the marker in the treated patients, and you can see over time, this is the first cycle, this is after 6 months. In all patients, this marker of oxidative stress came down nicely. And in drug development, if you have 2 signals in a phase 2 trial, a clinical signal and a biomarker signal, you feel very encouraged to move on to a phase 3 trial. And this is exactly what Mitsubishi did. So again, it was a lead-in design. There was a 12-week observation period. Patients were then randomized to placebo and to Edaravon, 60 milligrams per day. And this Each cycle lasted between 10 and 14 days. The problem is that Edaravon has to be given via intravenously, so it's not a tablet. And when they looked at the study results, bad surprise, there was a difference between the Verum group and the placebo group. Again, this is the change of the ALS-FRS score, meaning the larger the change, the more the patients deteriorate. But the difference was not significant. You see, the Edaravon group had a smaller change than the Verum group. But the company looked very close at the data. And what they found when they looked with respect to the category, that the difference between placebo and Verum was only 0.4 in the probable lab-supported group, it was 0.9 in the probable glue group, and 2.0 in the definite group, suggesting that the LS choreal category determines the response to Edaravon. Now, how could this be? Well, when looking at individual patients, what you see here is the change of the ALS-FRS from baseline within 6 months. 0 means no change at all. And -15 means the patient has lost 15 points on the scale. And what you see, there were many patients in the placebo group with minimal progression or slow progression. And those patients had mostly a symptom onset more than 2 years, were in the possible or probable lab-supported group, and a forced vital capacity below 80%. So then they did a post hoc analysis, and they found that in a certain subgroup, Edaravon showed a significant effect. And this subgroup was termed efficacy expected subpopulation. And the criteria in this subgroup was a diagnosis of definite and probable, forced vital capacity of at least 80%, disease duration of less than 2 years, and a score of at least 2 on all 12 items of the ALS-FRS score. And in another phase 3 trial, denoted the 19 trial, these criteria were applied. And just to remind you, this was the 16 study, which failed. There we had the probable lab-supported diagnosis, forced vital capacity was 70%, and disease duration 3 years. And in the 19 study, when these criteria were applied, the placebo curve shifted dramatically. The brown dots are the 16 trial. And you see again the change from baseline to week 24. And you see many patients did not progress at all. And if we look at the figures here, in the 16 trial, 36% were minimal progressors, only 13% in the 19 trial. 17% in the 16 trial did not progress at all, but only 6% in the pivotal 19 study. And of course, if you conduct a trial over 6 months, you do not want to have 17% with no progression or 36% with minimal progression, because this is going to ruin your statistics. So, and after the 19 study was analyzed, it turned out that this was positive. You see a dramatic change between placebo and Verum. The difference was 2.5 on the ALS-FRS scale, and it was highly significant, and also quality of life was significantly different. And this is the graph. Again, cycle 6, this is the 6-month placebo-controlled period. This is the Verum group, brown is the placebo group, and you see there is a difference in the ALS-FRS score, and then patients in the placebo group were also switched to Edaravon. I do not recall any other medication which has sparked so many discussions. Amongst the European ALS centers, this is the publication, there was more disagreement than agreement. And this is also reflected if you ask the big giants of ALS. For instance, Albert Ludolf was asked, is the published effect of Edaravon treatment relevant for ALS patients? And he says, I believe the effect of slowing down the ALS-FRS score by 1/3 in 24 weeks is a significant one. He was also asked, is an intravenous infusion of a drug administered appropriate? And he said, well, only based on the history of the drug, because it was first developed for stroke. But now look at that. John Turnbull, a highly estimated colleague from Canada, I'm not sure, Dr. Al Madani, you probably know him. He wrote an article in the ALS journal entitled, Is Edaravon harmful? And he comes to the conclusion Edaravon, as presently delivered, may be both ineffective and harmful. My colleague Tom Meyer from Berlin, I apologize, I got this from the website, so it's in German, but I will explain this to you. He asked his patients who were under Edaravon on a scale from 0 to 10. Green is 10, red is 0. How likely is it that you would recommend Edaravon for another patient? And as you can see here, 3/4 of the patient says, yes, give it to the other patients as well. So this is a patient-reported outcome measure. Another question is, does Edaravon work longer than 6 months? And this is, again, a post-hoc analysis of the initial data. So what the authors did, they took the 6-month data of the placebo-controlled trial, which is here. And then they projected the course for another 6 months, which is the gray line. And they compared the projected course with the actual course, which are the blue triangles. And what you see, there is a perfect match, meaning even after 6 months, the slope of progression in the treated group remains the same. And then they did exactly the same for the placebo group. They took the 6 months data, which are yellow here, which is the gray dotted line, and projected the line for another 6 months, which is here. But they were switched to Edaravon, and see, it definitely changed the course of the disease, implying that even if you give Edaravon after 6 months, it still will alter disease progression. Now, but what does this mean to a patient? A difference of 2.5 on the ALS-FRS score. Here are some of the items. It's a Kaplan-Meier curve, and what you see, if you look at the patients, again, that's from the initial trial, it's the transition from 3 to 2. The 2 transition means that the patient needs help. There is not much difference between blue verum and brown placebo with respect to turning in bed. But with respect to walking, it seems that patients on Edaravon can walk longer independently. And if you look at climbing stairs, the difference is even larger. Another way to look at the Edaravon data is if you apply the clinical staging system from King's College London. It's fairly straightforward. 0 means no symptoms. King staging 1 is involvement of one region, two regions, three regions. King's 4 is substantial respiratory or nutritional failure, and 5 is death. And Amar al-Chalabi did the analysis and found, if you look at time to any event, so any change in the King staging, that this is the Edaravon group and this is placebo, and again, they deviate from each other, and this is maintained in the open label phase. He also looked at the patients who do not change at all, meaning these patients remained in stage 1. So only one region affected. And what you see, these are the Edaravon patients, and these are the placebo patients, meaning in the placebo patients progress faster to a second region. And of course, in the meantime, there have been other studies. An Italian multicenter experience here from Asia, a study. This is another study. This is from Korea, this is from Asia. And this study here is from Kuwait, looking at various aspects of disease progression in Edaravone patients. And I'm just going to highlight the study from Kuwait. What they found is a significant functional decline, what you see here. They also applied a lead-in design, meaning they observed the patient before and after treatment. It was a non-controlled trial. And what you see before treatment, the slope of deterioration was 0.71, and after initiating Edaravone, it was only 0.43. And this difference was highly significant. They came to the conclusion that Edaravone also preserves respiratory function, but they found a high level of dissatisfaction. And this is the latest publication, which came out 2 weeks ago from the German MND network. And this was rather disappointing. Again, it's not a controlled study. But what they did, they took 119 patients and matched them with another patients not on Edaravone. Blue is Edaravone. Blue is the controls. Brown is Edaravone. And what you see here is the progression rate on the ALS-FRS score. There is no significant difference between Edaravone and control. So we are somehow left with a discrepancy in terms of uncontrolled trials, some showing improvement, some showing no effect of Edaravone. When I ask my patients, and I do have a few, but you know, this is not science, this is just patients' example. One told me my head control is much better, and I could confirm this with the neurological exam. Another one tells me I can walk better and get up from a chair. I can lift my foot much better and therefore can climb stairs again. I feel more stable. One patient talked about improved tiredness and fatigue. And before treatment, I could walk maximum 10 minutes without mask. Now it's up to 1 hour possible. I'm more vital. I'm able to open bottles again. And I have an increased walking distance from 300 to 1,500 meters. I'm not saying that this is science. I'm just pointing this out to you here. And this is from a US study looking at everyday practice of the application of Edaravone. What you see here is that 67% use riluzole plus Radicava, and only a minority uses Radicava alone. If we look at the order of use, the vast majority, 84%, start first with riluzole, and then Radicava is added. And if we look at the method of administration, almost 60% have a port, 21% a PIC line, and 18% a peripheral line. And the site of administration, many patients, but again, this is the US, many patients get home infusions, 26% at the referred site, and 32% at the physician side. And now I will briefly leave Edaravon and touch a little bit on future developments. So what is on the horizon? And now I'm going to show you a few spectacular movies and slides. The greatest progress has been made in the genetic forms of ALS. And you know, the first mutation which has been described is SOD. Well, in SOD, the story is pretty much forward. We have a toxic protein, and all what we need to do is to silence SOD, and we can do this with viral vectors. And now I'm going to show you an SOD mouse model. Now look at this. This is an SOD mouse, and this mouse has great problems swimming here. It can hardly get to the deck. And now what you see is an ALS mouse treated with a vector. Now look at that, the hind limbs. This is quite a difference. So as mentioned, in SOD, this is pretty much straightforward. You know, we have the DNA, we have the mRNA, and then we have a toxic protein. And all what we do is we apply an antisense drug, which is complementary to the messenger RNA, and no SOD protein is made. And there have been two studies with tofersen, which is an oligosense antinucleotide. And the first study, like in Edaravon, was very, very promising. Again, we have the ALS-FRS score. This is the whole group. Brown, you see the treated patients. Blue is placebo. And this is the slow vital capacity. Brown, verum, blue, placebo. And what you see here is the most aggressive ALS form with SOD mutations. This is the A4V mutation. These are treated patients. There were only 4 with tofersen, and this is the placebo group. Amazing results. Likewise, forced vital capacity, placebo, blue, verum group, brown. Quite spectacular. And again, after this study, Biogen launched a phase 3 trial. There was a randomization 2-to-1, tofersen 100 milligram versus placebo. And the primary outcome measure was again the ALS-FRS total score. And they had 2 different groups, fast progressors and slow progressors. And this is the VALOR study. The fast progressors are here, and what you see, the dashed line is the placebo group, the solid line is the verum group. These are the slow progressors, and after 6 months, no significant difference. These are the fast progressors, and again, no difference between placebo and verum. And if we look at the open label extension, you have the impression that after 7 months of treatment, which is here, again, the placebo patients were switched after 6 months to verum. You have the impression that after 7 months, also the placebo patients, which are now also on tofersen, remain stable. But no difference here in the most aggressive form. Same respiratory function, slow progressors, no difference. There is a difference in the fast progressors, but again, not significant. And here again, open label extension, slow progressors, no difference between Verum and placebo here, and in the fast progressors with respect to forced vital capacity, there seems to be a difference. One question was, do we have a biomarker pre-symptomatically? Well, neurofilaments are very popular. And what you see here is the discrepancy between a biomarker, which comes down immediately in both. We see here fast and slow progressors. The neurofilaments go down very, very rapidly in this trial, but not in the placebo group. And here, again, open label extension, when you switch the placebo patients to tofersen, also neurofilaments will go down. The problem is we have a biomarker which shows target engagement, but this does not translate into any clinical effect. Nevertheless, there is an open early access program with tofersen. All you can apply for this program, and you will get the medication from Biogen. If you have patients with SOD, you can give it to them. And now I'm going to talk to you, and this will be my last slides. I'm going to talk about another mutation. This is a FAS mutation. FAS means juvenile ALS. So these are young adults with a very aggressive form of the disease. And with permission of the patient, I am showing you these slides. Now, Anna is a 17-year-old young lady who developed symptoms about 2 years ago. And she is also treated with an oligosense antinucleotide medication. This medication is called Jakifusen, and the company has just launched a phase 1 trial. And this was she was started in July. She got worse, and this is how she was walking stairs on 8th of November. She is on a ventilator. Watch her left hand and how she is climbing stairs. This young lady is so amazing, and she is fighting against the disease like a spider. She is crawling up. She is crawling up with her hands. And as you can see, she's going step by step. And now, this is 3 months later. She's still on the ventilator. But now, look how she walks the stairs now. To be honest, I've been in ALS for 25 years now. I have never seen such an effect in any of my ALS patients. And with that, I thank you for your attention, and I'm looking forward to a nice discussion. So thank you very much.
Thank you, Dr. Weber. Very nice and extravaganza speaking style and lecture. A question from my side. Do you use Edaravon after 24 weeks?
Yes. Well, yeah. I think this open label extension study from Scheffner showed that even if you give it after a longer period of time, it still works. So we do not strictly adhere to these criteria. But yeah, because we simply don't know.
We have many questions from patients as well and from the audience. Is there a role for stem cell or gene therapy?
I'm very skeptical with stem cells. The reason
I had 2 of my patients who went for stem cell and they are in ICU.
Any improvement?
No, they are in ICU, still in ICU.
You see, I think it's too early for stem cells. I'm not saying that they are useless. The problem is the idea that stem cells can replace motor neurons is ridiculous, because we have a single motor neuron in the spinal cord, and this single motor neuron receives 60,000 synapses, has 60,000 connections with upstream, and this is so complicated. Even though we can re-establish a motor neuron, the wiring is important. We cannot re-establish the complicated wiring. If we play the piano, this is such a complicated movement. The wiring is crucial.
There is one thing I need to emphasize. I want to make sure that you agree with me. Every single patient who has been diagnosed with ALS, I send them for sleep study. The reason is because there is data for CPAP and improving outcome. Do you agree with this?
I fully agree with that. In the meantime, we have plenty of data showing that CPAP, non-invasive ventilation, has a profound effect on survival, but also on quality of life. Yes. I really like to re-emphasize that. It's about quality of life primarily, but also about survival. I agree with that.
There's a question here. Is there a data ALS getting provoked by COVID vaccination? That poor COVID vaccination is blamed for everything.
You know, vaccination can make almost everything. Well, I've seen brachial neuritis, I've seen CIDP with COVID, I've seen Parkinsonian symptoms. I have not encountered an ALS patient yet, but I can't know for sure. I don't know.
A nice question here. How do you manage pseudobulbar symptoms?
We give escitalopram, which works within a week. However, having said that, if there is hypersalivation, sialuria, we go for tricyclic antidepressants like amitriptyline, because then you treat hypersalivation and emotional lability. But otherwise, you know, we go for the modern SSRIs.
I agree fully with you. I have good experience with TCA, tricyclic antidepressant.
Yeah,
it has dual effects, and they sleep very well because most of them are anxious.
Yes. I agree fully with you. Yeah.
I have nevertheless seen very classical ALS patient, very classical one. Then in a few months' time, they turn out to have some sort of malignancy. How common you see this?
Sorry, I missed your question.
Very classical ALS.
Yes.
Who turn out to have malignancy later on. When do you suspect malignancy, or when you suspect paraneoplastic?
The problem is weight loss. Weight loss is quite common in ALS, so you can't tell in the end, is this paraneoplastic or not. Well, we always ask for. Sorry, now I'm missing the name. You know, regular checkups for cancer in women, breast cancer, and in men, prostate, and so on and so forth. But yeah, usually before the patients come to us, they have had extensive lab work and other examinations. So and of course, sometimes if you look at the cancer patients have they look differently. you know, they look really sick.
Mm.
But most ALS patients, when you see them the first time, they look actually quite healthy. But of course, if you have a lot of weight loss, I think it's always worth checking for cancer.
Is ALS caused by virus infection?
Don't know. I think the greatest risk of getting ALS is genetic predisposition. When I say genetic predisposition, I'm only referring to a certain risk factor. And then we have environmental factors. There is a nice study by Amar Al-Chalabi showing that it takes 6 different steps until you develop ALS. But the point is, if you don't carry the risk gene, you won't get ALS. If you carry the risk gene, and I'm talking about a sporadic ALS, if you carry the risk gene, it may develop or may not develop, but we don't know all the risk factors which eventually lead to full-blown ALS. It's the same with lung cancer. If you don't have the risk gene for lung cancer, you can smoke like a chimney. But if you have the risk gene, you better stop smoking right away. So this is...
It's almost now 9:28. So I have last question here. Can bypass obesity surgery trigger ALS? I'm not aware of this, but...
I don't know. But my old boss, Andrew Eisen, Mike Swash, all the old guys say, once you have ALS, stay away from the surgeons. I don't think that any surgery may trigger ALS, but once you have ALS, it may accelerate the disease.
Okay. Hereby, I thank you very much, Dr. Weber, for your excellent talk. It was mouth-drooling topic with many good and bad news, of course. ALS is a bad disease, I always call it, but it's treatable. It's not treatable. It's not, people don't die suddenly from ALS. It takes time. How long it takes, we don't know, but usually it takes the same task as the patient. My patient, for example, he says that 50% of my power reduced compared to last year. Yeah. So the same pace will be going on for the next few years. So that's a good thing about ALS, and we consider it as nice people disease. Do you agree with this?
True. Yes. ALS patients are always nice.
Yeah. So thanks very much. Thanks for all audience for being patient with us and this weekend and listening to our talks. And I promise you for more neuromuscular series in this year for the next few months. Thanks a lot for everyone.
Thank you so much. It's been a great honor to talk to all of you. I apologize because we don't have time to answer all the questions, but send me an email and I will reply to you.
Sure. Thanks a lot.
Okay.
Thanks
Thank you, Dr. Al Madani. Thank you, Biologix.
Thank you.
It's been a great honor and pleasure. Have a nice evening.
Thanks, Biologix, and thanks, MCEO, for organizing this.
Yes.
meeting.
Thank you so much.